So, a very good evening, Dr. Duarte, once again. I'm really happy to see you one more time and having this long-term follow-up on our previous webinar.
Yes, it's always a pleasure to be here to present the cases and to give the follow-up of this product that is CERASORB Bioactive, that I have now a good experience, I can say that, in very challenging surgical cases. Today we brought some different cases that will show how the biomaterial works. I'm based in Portugal, in Porto. As I told you now, I just do oral surgery and implants. I'm specialist on this, and also now I'm the president of the European Federation of Oral Surgery and also the president of the Portuguese Oral Surgery. For today, as introduction, just to remember the colleagues that the CERASORB Bioactive is a non-organic porous biocompatible bone graft containing about 40% of silicone made for filling, briding, and also reconstruction of the bone defects. It's quite important that you have a reliable material that can help us during our challenging clinical situations. It's completely synthetic, it's biocompatible ceramic material, and its porosity of 75% is quite helpful when we mixed the biomaterial with the blood, creating, for instance, the sticky bone. Compared to the biomaterials of biological origin, eliminates also the laborious treatment with alkali and heat for the removal of the organic components, what is quite important. As I told you, as a synthetic biomaterial is excellent for intra and extra osseous tissue compatibility without any kind of local or systemic toxicity. It will resorb in 4 to 6 months in contact with vital bone. The material is resorbed by the body over a period of this time and replace it by endogenous bone. Radiopaque is available in granulars, is easy to handle, is easy to put in the bone defect and work with it. This is the type of situation that we received the granulars, quite interesting to show. Now, our first clinical case combines 2 different technologies, not only the bone reconstruction, but also the laser. We felt that sometimes we don't clean completely the bone. This is the major complication, because we have a tooth, we have a cyst, we have an infection, a drainage, a pus with granulation tissue, and we think that we clean well our alveolus, our bone defect. And because we don't have microbiological eyes, we just go by mechanical curettage. And now we don't do it anymore only by mechanical curettage. We need to have an extra tool that is the laser. And for that, I will show you a first paper from the Frontiers in Materials from 2022, that we can see that if we clean the bone, autogenous bone, before we place an implant with the laser, the results will be quite impressive. We use 2 wavelengths of laser, the erbium and the neodymium, but just to compare, before we place the implant, 3 different situations where we clean the bone with the erbium, and we will see that after 14 days the bone around the implant is interesting. When we do it with neodymium, less bone around the implant. When we do a combination with erbium and neodymium, the quantity of bone around the implant is very important. We would like to prove the point that sometimes the biomaterial needs an extra help, needs to be placed in the socket without infection. Because when the things go wrong, the clinician will say, okay, the biomaterial has no quality for this bone reconstruction. And it's not true. The question is, sometimes we need to control the microbiology. Now, this is a very interesting case that came to us to retreat. And now we live the era of retreatments. Now, 25% of our clinical cases, new cases, are retreatment. And they try to place implants on this gentleman for 3 times on the mandible. And the patient came without any kind of oral rehabilitation, fixed or removal. They came with this situation. Now, let's go and analyze the bone of the mandible. We have one implant alone that was left there just to try to give some kind of primer stability to the removable prosthesis, but the patient refused to come to have a removable prosthesis. But we can see that the mandible is completely perforated with several attempts of place implants. And this is the OPG. When we go to the CBCT, the situation is even worse. There is no vestibular plate, there's no medullary bone. It's only lingual and cortical bone for reconstruction. And they even perforate the inferior border of the mandible, as you can see there. Now, quite a tricky and challenging case. And the patient came to us with very funny ideas, like placing implants again, in-depth loading, and this and this and that, and told him, no, we are one step behind. We should do the bone reconstruction. Wait, but before we do the bone reconstruction, it's quite important for us to clean the bone, the autologous bone, to receive the biomaterial and to have a fusion. Microvascularity is so important. Absence of granulation tissue is so important. We need to create conditions for our biomaterial to survive. And there are some areas in the mandible, mainly in the symphysis areas, that we only have 2-3 millimeters of cortical bone. Now, as you can see there, it was an extreme situation. And the 3D bone reconstruction is quite an example. We didn't quit the case. We explained the case to the patient that we decide that we will do it together with time. Okay, it's quite important that we explain and lower the expectations of our patients. With the laser, our protocol is a protocol with several steps. Degranulation is the first step. Remove the granulation tissue. The disinfection of the autologous bone is also important. Depitalization, the clot stabilization, because we need blood not only for the autologous bone but also for the biomaterial. And in the 5th step, photobiomodulation. Photobiomodulation, it will increase the healing process of the soft tissue and also of the bone. Is why the case is here to show how we can manage with these new protocols with our biomaterial. And in the same surgical time, we will do the bone reconstruction. And it's quite a mandible 3D bone reconstruction. Let's see what we got. This is the laser protocol using the erbium and the neodymium. If you are not so familiar with the laser, I can say that erbium it cuts soft tissue and hard tissue and goes deeper in the tissues, but the neodymium goes even deeper, is a little bit more aggressive when we compare to the erbium. The less aggressive lasers available in the market are the diode lasers. Now, here it is our situation. We start by doing a full thickness flap we identify bilaterally the mental nerves, and we start to remove the granulation tissue that we try to create healthy conditions for our biomaterial. It's important to go alveolus by alveolus, disinfecting all the bone conditions, as you can see there. On the bottom, the left-hand central images is with the erbium, the right images is with the neodymium, and we lose more time in disinfecting the bone than reconstructing the bone. Here we use the CERASORB Bioactive mixed with the blood from the patient, and as you can see there is a massive bone reconstruction. It's challenging to see what we will achieve during the time, and we have all documented. We place on top of it, we place the membranes, we place host guide membrane, we place also fibrin membranes, which stitch very well, and we even place an extra protection with the periacryl. It's like another glue. The patient couldn't use the removable prosthesis for some time. He was not using it anyway, but we advise him to have an extra care. And this is the follow-up at 3 months of follow-up. Okay, from the OPG, we can see that is some kind of interaction between the autologous bone and the CERASORB Bioactive, but it's not so clear. For this kind of evaluations, I always like the CBCT. Let's go for the CBCT. Interesting images. We can see that we increase the depth and also the weight of the bone reconstruction, but there are some gaps, as you can see there. 3 months follow-up. There was no full compatibility between the autologous bone and the biomaterial. But of course, early days, because it's a very challenging case. The microvascularity around this bone was very, very insufficient. We cannot say that we have the perfect conditions. On the other hand, very difficult conditions. And also the soft tissue coverage of this bone is also quite interesting. But now, see that there was no bone resorption. The bone was there, not fully compatible on X-ray for now, but we don't see in the cell level what was happening here. And we can see from all the cuts that we have, the space, and this was after three months. Now, let's keep following the case and see our results. They were quite promising because from the patient point of view, there was no infection, there was no redness, the tissues were very okay. This is the images from the 6 months of follow-up of the case. Again, the patient was quite happy, and see how things are changing. Okay, now another OPG with 6 months. It seems that we don't see so many gaps anymore. It seems that now we have a compatibility between the autologous bone and the CERASORB Bioactive. When we compare the degree of resorption, it seems that there is no resorption at all. We now have a continuity in our bone. Let's go for the CBCT, the reconstruction of the CBCT. Here it is, no gaps, compatibility between both bones, reconstruction full formed. Even the most deepest sockets, they have bone now. We have subtract to place our implants. Of course, still a difficult case, but it will always be a difficult case. But the bioactive, it was its maximum because a very challenging case. But we didn't finish the case like this because, as you can see here, there is completely continuity without any gap. We still followed the patient, and after 6 months, we reoperate the patient. And they are very nice images because you see there is real bone giving primer stability to our implants. And we managed to put 6 implants. They are not very long, they are short implants, 8.5 millimeters. We try to split our implants for all the mandible, getting implants in the anterior region, middle, and also posterior region of the mandible. Trying to get the most well biomechanical position as we got. We remove the implant that was in the fourth quadrant in the posterior area. It was only there to help us during this healing period, and we close it again. But interesting to see is the clinical image, because the bone was compact. It was not granulous anymore. The implants got primer stability. And when you look to the image, it's easy to understand that it was a safe bone to place our implants. And we can see it now after we place the implants. And again, sometimes it takes us a long period to reconstruct the case. It's not an easy case. This kind of cases that we are retreatment of patients is quite as challenging, and a chapter by itself is difficult to got this. But see the diameter of the implants and the diameter of the bone that we got after the reconstruction. And when we go here, we can say that, of course, we are trying to manage and explore all the bone available on the patient. I will not deny that, but we are trying to maximize our bone. But on the other hand, we have implants placed in our bone reconstruction in a good level. We managed to increase the quantity of the bone, and we got 6 implants over there. And when we go to see the cuts, the sagittal cuts, you will see that the implants are well positioned, and we are waiting for the osteointegrated time of the patients. There is no implants loss until now. There is no bone resorption until now. And again, is a case that we are following for 10 months now, and we will do the rehabilitation at 12 months, what means that the first bone graft was with a waiting time of 6 months, and the implants will be also with a waiting time of 6 months. It took us 12 months to do this case. Interesting and new things, new techniques that we done. The autologous bone disinfection with laser, okay, using a dual lamp with erbium and neodymium, and also the application of photobiomodulation directly on the biomaterial. It seems that the acceleration of the healing process is quite important, not only for the soft tissue, but also for the heart tissue. Now, the second case is also a retreatment case. Very, very interesting. This paper is one of my papers that I like most. It's from a journal that sometimes the people don't read often, that is the Applied Sciences. It's a paper from 2022, and we talk about the microbiome that is in the mouth. And it's a very long paper, and there is a table that got my attention, and that I will spend a little bit more. Because when we say that we are talking about healthy peri-implant sites that are in the red definition, you will see all these bugs, all these microorganisms present. And we say that it's healthy. Imagine, healthy. When we look to the periodontitis, is the blue, and the number of bacteria, it will increase. And when you say peri-implantitis, see the green is nightmare. They are all present. It's unbelievable. Now, how can we remove an implant and just do mechanical curettage, place another implant, and do bone graft at the same time and wait that everything will work properly? It's very, very difficult. Again, we are placing the laser on these sockets and try to get the better result. Why? Because the spirochetes, they will interfere with the osseointegration. And sometimes clinicians lost the implants. They say, oh, it was the biomaterial. There is bone resorption. Oh, it was the biomaterial that was working well. No, it's completely wrong. The problem was we didn't create microbiological conditions for the implants to osseointegrate and for the bone also to consolidate. Very young patient, okay? The rehabilitation is with 2 years, and the patient was referred to our clinic because she is 42 years old. Heavy smoker. First treatment was what I call disintoxication, okay? We just say to the patient, you cannot smoke so many cigarettes a day. It's completely impossible. We cannot treat you. Because when you say the truth to the patients, my feeling is that they will understand. When you say, okay, if you don't change anything, I will have the same results that my colleague have. I cannot have better results. You need to change it. And we wait for 3 months for the patient to prove that she will be able to change. When she returned, again, now I'm able to do the treatment. And this image doesn't seem that we have a problem. But when we go to a close look, okay, maybe it's wrong with the case, maybe choose badly the case, maybe it's not the proper case. Wait for the next image. This is a nightmare. 2 years of treatment. The implants are almost all exposed. You almost say hi to the bacteria. Or say, hi bacteria, I'm here. How to treat this kind of cases? Quite difficult. And this is the OPG of the patient. There were, 7 implants. There was no load in one of the implants. There was a massive bone resorption. And the problem is it was already a severe maxilla. And of course, we need to find new sites to place implants, the zygomatic implants, the pterygoid areas, the subnasal area, okay. But first of all, we need to control the microorganisms. If not, we will not be able to do a bone reconstruction and the implants placement for with some good expectations to this patient. And when we go to the CBCT and we go with some kind of hope, waiting for bone, autologous bone, there was no bone. The resorption between the implants was massive. It seemed that all the implants were outside the maxilla. Plus the degree of infection, the degree of soft tissue granulation, the mobility of the implants when we took the removal, the prosthesis, is quite challenging. And this was one of these cases that you need to open to see what will you find and to get almost a treatment plan during the surgery intraoperatively. And here it is, we were looking already to the zygomatic bone because for the posterior implants, we will try to go for a zygomatic implant also. Now, the 3D reconstruction, can you imagine, 42 years old, without any bone supported anterior premaxilla. And here it is when we remove the teeth. You will see that the implants, they were mobile, they were infected, and they were with drainage of pus, mobility. They can very easily, was not difficult to remove, to extract the implants. But the problem is what to do after that with a so young patient. Now, here it is, again, introduction of the new technology, introduction of the laser protocol to remove the demyelination tissue, to disinfect the autologous bone, to depitalize, trying to create microvascularity and conditions to do also our bone reconstruction with CERASORB Bioactive. And all the implants are completely intact, as you can see here, bottom image. And now the second stage of our surgery was how to place implants, how to reconstruct all this. Now, different applications of CERASORB Bioactive. Subnasal locations and subnasal placement of the CERASORB Bioactive. We elevate the nasal membrane. We place the implant and we'll fulfill all the space with the biomaterial. We didn't pack it too much because of the membrane, but we managed to have a good primer stability of our implants. Here we put also the photobiomodulation directly with the biomaterial. Each time I believe more and more that the healing process can start during the surgery. And we try to reconstruct all the premaxilla with the CERASORB Bioactive. No loading, just waiting for 4 to 6 months according to our radiological control to see what happened. Here it is, removal prosthesis of the patient. A good clinical aspect, at least it's not worse than when she came to us. This is the aspect, and let's evaluate. Now, we are trying to maximize all the areas of the patient with zygomatic implants, with pterygoid implants, or reinforcement of the pterygoid area also with the CERASORB Bioactive, because the bone over there is not so good. The bone reconstruction of the subnasal area with the implant placement, also implant placed in the intra-incisive foramen with where we have the nasopalatine nerve, and also adjunctive therapy with the short implants that we're trying to place. And I strongly believe that the future will be retreatments. The number of the implants are placed worldwide without any kind of follow-up program for the patients. Some of them they start to have complications, and with as the age goes by, I think we will have more and more of these patients to treat. Now let's go for our control CBCT. You can see there the quantity of bone that we place, but also the compatibility between the biomaterial and also the autologous bone. You will perfectly see another application of the Resorb, the CERASORB Bioactive in the subnasal area. The subnasal area is nice because it's heavily vascularized, what means that we will receive from the nasal membrane blood, and is quite good for the bone grafts, and is one of the areas that we are exploring more and more. This kind of porosity works perfectly well in these new areas, and even in the pterygoid area, that as the bone is not of so good quality, we can give more support to our implant with the biomaterial, compacting it around the implant. Here it is a control also. and the patient is already rehabilitated. As you can see here, the implants placed, no any kind of complications during the healing period. Of course, it's also important to advise that the company has this guided tissue and bone regeneration booklet, and also a study book with clinical cases. It's so important to see and to feel the quality of the products that we are changing. We live now a different era about implantology and bone reconstruction. I think that we should analyze what we do. If you are comfortable or not, we think in a long-term basis. The implantology should be seen as a long-term basis. And of course, I live with a sentence from William Shakespeare: there is nothing either good or bad, but thinking in the way we think make it so. Because it's quite important that we leave our clinic with a feeling that we've done everything well for our patients. We just live once, and we should live it according to principles and to good practice. Again, I'm quite happy with the results that I achieve in the long term with the CERASORB Bioactive. I try the product in very difficult clinical situations and surgically demanding cases, and the biomaterial is behaving quite well.
Thank you so much, Dr. Duarte, for your time and showing us and walking us through such an extensive cases and very difficult cases. That's really commendable with the results and so on. In the first case, you mentioned that the implant size was around 8.5 mm. And in the first instance, we could see that the patient was completely edentulous with some soft tissues and soft muscles. Based on that, were you able to measure how much height or width was able to recover after reconstruction?
Yes, it's a very good question. We can measure the volumetry of the bone that was reconstructed. We are waiting for the final follow-up with the rehabilitation, and we will have that data. Because I'm also very, very enthusiastic with this kind of results. We can measure it, compare, because we have CBCTs from all the stages. What is good? We can have the results at 3 months, okay, without implants, at 6 months already with implants, 9 months and 12 months, okay?
Okay.
Because to publish, we need at least 12 months of follow-up.
Okay.
And we are now entering the final stages with 12 months of follow-up. But the results, preliminary results, are quite promising, that we will have a good volumetry in terms of, I think more now in the 3D way. I think we should start to think like the volume of bone that we increase. Because in this digital era, I think it will be more valuable to start to speak about volume, increase of volume around the implants. Very shortly, we will have this kind of results to show you.
Perfect. I am looking forward to it. But you mentioned that you were able to get the stability for the implants while placing the implants, right?
Right, completely right. When we compare the results that we have with the bioactive, is one of the major advantages. When we go to a second stage surgery and we place the implants, in my opinion, according to my clinical cases, the primary stability is higher. Okay? We are losing less volume, is one of the characteristics that I can see clinically, and the primary stability of our implants is higher. The compatibility between the bioactive and the autologous bone, I think, is also higher. The bone density makes difference when you place implants in the sites that you done bone regeneration.
Yeah, and as you are speaking now, you pressured a lot on primary stability. Why do you think it's so important in the second stage while placing the implant?
Yeah, primary stability is quite important because if there is some degree of mobility, we will have fibro integration and we will not have osteo integration. Plus, when we say that okay, the implant is completely osteo integrated, there is no 100% contact between the implant and the bone, and this is well proven. We were talking about 75, 80% of interaction between the implant and the bone. And we call it osseointegration. But don't forget that there is no masticatory movements yet. When we start to bite, this will change completely the scenario because the implant will be with some kind of strength. The occlusion is fantastic because if there is no osteointegration between the bone and the implant, we will lose the implant and the rehabilitation in the later stage. It's why it's so important to guarantee from the first moment this primer stability because it's already a very good percentage without mobility, and the rest is blood, bone, and physiology, waiting time. It's important also to give to the biomaterials, to the bone, to the body, time to heal. Is why we now incorporate the photobiomodulation. Because sometimes it seems that the clinicians, they want to accelerate so much the process that physiologically they don't allow the bone cells, the blood, to make their healing time.
One more question related to the first case. I'm sorry if I have completely missed this point. What was the age of the patient by any
60,
chance?
no, 65.
65. And he was completely edentulous. Um, in this scenarios, mostly when you are above 60 or above 70, usually the dentist usually or the surgeons usually prefer uh, like a material which is only going to give a volume, like the integration material, bone integration material. Why did you choose a bone regenerative material like a CERASORB Bioactive on, like, when you could have chosen any integrating material like a xenograft or something?
I think we should, each patient is one patient, of course, but if we strongly believe in our biomaterials, in what we do, I think that we can provide better quality of life of our patients. And the wish of this patient was to have a fixed dental rehabilitation again,
Mm-hmm.
and feel more comfortable with because I'm using for a long time to do a proper bone regeneration in this kind of cases. It's not it's a learning curve, and I learned a lot with biomaterial, not only to win volume, because when you see the clinical images, when you reopen again and you go there, of course I go there to place the implants, but I see the quality of the bone, I see the volumetry that I win, I see that there is one monoblock between the biomaterial, the active, and the autologous bone. There is no, okay, this is autologous bone and this is a coverage of some kind of bone. No, it's a monoblock. Is why I choose the bioactive.
Yeah, do you have a trick while using on which kind of patients would you use bone regenerating material versus in which you would just use or volume stability material? Do you have something like how do you decide on your cases?
When the defect is with one wall, okay, you don't need the bioactive. You can use the other biomaterial because it doesn't make the difference because the microvascularity comes from all the other walls, okay? Of course, you can also use bioactive, but it will not make a major difference. But when you have a three-wall defect or a two-wall defect, I think the bioactive will do the difference. And this is my major criteria to
Okay.
differentiate between one and the other.
Okay, perfect. Thank you so much. And a very quick question on your second case. You mentioned that it was a periodontitis case for sure.
Yeah.
And you did a subnasal application for it. What are the things which the emerging surgeons need to keep in mind when doing a subnasal applications with biomaterial? Like, which is that one crucial things which they shouldn't miss at all?
Okay, it's a fantastic question also. The floor of the nasal area should be intact. What means when you are doing your flap, if any reason there is a rupture of the nasal membrane, you should stitch it before you place the biomaterial. Why? Because you are creating an open access to the nose, okay, a bleeding area, okay, and it's not good for your biomaterial. Your biomaterial bioactive should be there concentrated to that area, and the pressure, the subnasal pressure, is quite important because we'll keep the biomaterial in the right place. Okay, you don't need anything more, just to breathe. As you breathe, there is a air pressure and it will give pressure on the subnasal mucosa and the biomaterial will be there. Again, you need at least 2 millimeters, 3 millimeters to stabilize your implant in the cervical area. But all the other complement from the needle to the apical part of the implant, you can do it submerged in biomaterial. There is no problem. That area is also high vascularized. What means that the material will have a high degree of density.
2 or 3 indications where you would highly prefer bioactive over anything else, and why?
Mandible reconstruction, as I show here, for me is one of the major indications. It is difficult, but it works well. The case is difficult, but it works well. The subnasal area, bioactive is quite good, and also the pterygoid area, the posterior area of the maxilla, I think will be disruptive with all the biomaterials because we are using not only extensively, like the mandible in the symphysis and parasymphysis region, that is not is a very critical autologous bone. It's difficult for the biomaterials to work there and not to be resorbed. And the bioactive has fantastic results. The subnasal area, because it's not used, because the surgeons sometimes try to avoid this area, saying, okay, there is no bone over there, there is no way of placing the implant. Okay, you can elevate the nasal membrane, and you saw it with good results. And when we have the lateral part of the maxilla without bone and we go to the pterygoid area, sometimes it's not so, it's a soft bone over there, and there is part of the implant that is exposed. We can do the bone graft with the bioactive also. 3 different anatomic areas, completely out of the box, but I think with very good results.
Thank you so much, Dr. Duarte, for your time and this extensive Q&A. Also, this gives a very good idea even to the emerging surgeons of how to proceed in some tricky regions and in tricky cases. Thank you so much.
It was a pleasure, like always, Nia. Thank you very much. Okay, see you next time.